Hello and welcome back to our series. We're grateful you're here. Hope you're enjoying the spring. This is our last session of the semester. We'll be taking the summer off and coming back to you in September. As you know, we are always expanding our educational offerings, including our growing collection of programming led by Drs. Armin Smith and Jeannie Hoffman-Sensis, and program team members Pamela Getz, Samantha Rockler, and Stephanie Cooper-Greenberg, specifically tailored around the experiences of women with bladder cancer. See our website for the next virtual women's group. Additionally, we've been working with our clinical providers to assure our GBCI front door for care is easy to access. We have two email addresses, bladdercancer@jhmi.edu, and a more specific email for upper tract urothelial cancer patients, utuc@jhmi.edu. Before we introduce today's session, I wanted to remind you that you can find our updated programming and useful resources on the web, including a new one-page bladder cancer patient navigation aid designed to help our patients understand the complex relationships between our unique teams and departments across the GBCI. You can download a copy from our website landing page or email us at bladdercancer@jhmi.edu to request this valuable tool. I'm grateful to Stephanie Cooper-Greenberg for editing our latest newsletter, which is available on our website. Or, if you haven't received a copy, reach out to us on bladdercancer@jhmi.edu. While on our site, I encourage you to take a look at our previous Grand Round series that are all viewable through YouTube. Again, more information for all of our programming can be found on our website. Google Greenberg Bladder Cancer Institute. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm pleased to introduce our expert today, Dr. Cynthia Boyd. Her focus will be on improving the health and health care of our older adults, many of whom are managing with frailty, mental health issues, and cancer. I'm grateful to our co-founder, Stephanie Cooper-Greenberg, for joining us today to host this most unique conversation with Dr. Boyd. Thank you, Stephanie. Dr. Boyd is the director of the Division of Geriatric Medicine and Gerontology. She holds a joint appointment in Health Policy and Management and Epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Boyd is a core faculty member at the Center for Transformative Geriatric Research, Johns Hopkins Center on Aging and Health, and the Roger C. Lipitz Center for Integrated Healthcare. A former Robert Wood Johnson Physician Faculty Scholar and a Beeson Scholar, Dr. Boyd is trained in internal medicine, geriatric medicine, and epidemiology. Her main interests include improving the health and well-being of older adults with multiple chronic conditions, as well as their loved ones. She earned her MD from Duke University School of Medicine and her master's in public health from the University of North Carolina at Chapel Hill. She completed a residency and fellowship at Johns Hopkins and did a fellowship in geriatric medicine and gerontology. Dr. Boyd has been recognized with several honors, including the American Geriatric Society's Outstanding Scientific Achievement for Clinical Investigation Award, election to the American Society for Clinical Investigation, and fellowship in the American College of Physicians and the American Geriatric Society. Her research has been funded by NIH, HRQ, PCORI, and other foundations. I'm glad to have both of them with us today, and I'll turn it over to them.
Hello. So I'm going to thank you so much for that really kind introduction, and I'm going to get started sharing my screen. Sorry for the difficulty, everyone. 4 years into the pandemic. I'm sorry, I'm still a tiny bit slow. I'm just trying to share the right version. All right. Well, thank you so much. I'm really glad to get started with all of you, and I appreciate the kind invitation to present to you all today. I'm going to be talking about improving health and healthcare for older adults with multiple coexisting conditions. Thinking about this in light of aging, which is, of course, a natural process that we all will go through if we're lucky to get to live long enough. Frailty, mental health, and of course, in the context of cancer. So I am a geriatrician, and I do both primary care and consultative care in Baltimore at the Beecham Center on the Johns Hopkins Bayview campus. And so my talk is really going to be about all the things that I think might sort of coexist around before, during, and after having cancer. And I hope that it's of interest to you. And I'm looking forward to Stephanie and your questions. I write a chapter for Up to Date on Multiple Chronic Conditions. So the first thing I want to do is just to give a big shout out to my colleagues. The slides that I'm about to share really draw on the work and expertise of a number of the geriatricians in our division. You can see some of them here whose work and slides and wisdom I'll be sharing with you. So my interest in this topic really goes back to my earliest experiences being a physician. In 2000, I started my geriatric fellowship after doing internal medicine residency at Johns Hopkins. And I was seeing some patients that had multiple chronic conditions, and I was trying to apply what we're taught so well in medical school and residency, which is what's the best care for each individual condition. But I found that when people were experiencing, 4 or 5, sometimes 7 or 8 different things, that model of sort of treating patients like a disease at a time and adding it up didn't seem to work very well. And we wrote a couple of papers about this early on, which I'll share with you. But in 2009, it was really a great honor that one of my patients actually got featured in a story in the New York Times about this topic, which has really, I think, changed the way many of us in healthcare think about the way we learn, the way we care for people, is that treating an illness is one thing, but how do we think about a person or a patient who has many in a way that feels holistic? So what you can see here is the treatment regimen that would arise if we took the clinical practice guidelines, which is kind of like the best available evidence, and applied them to a person with 5 chronic conditions. In this case, it's a 79-year-old woman with COPD or chronic obstructive pulmonary disease or emphysema, osteoarthritis, that's the wear and tear kind of arthritis you may have heard of, osteoporosis, that's the thinning of bones, high blood pressure, and diabetes. And we tried to make this, you're probably not going to believe me, but we actually tried to make this regimen as simple as possible. We tried to avoid conflicting things. We tried to avoid making it be in a complicated pattern. But you can see that this person would end up on 12 different medicines and 19 different doses per day. But that not only medications, there's a lot of other things that this person would be asked to do, which we often refer to as self-management. But another way to think about it, right, is it's the role that the patient is playing in taking care of their own illness. And they're spending much more time managing their conditions outside of our office than when they're in. And so but you can see that there's a fair amount, and it's a lot to be thinking about doing. And then on the final column, you can see the minimum that the guidelines recommend in terms of healthcare utilization. But we know that most people who have 5 chronic conditions are doing much more than this in terms of the number of doctors they're seeing, the number of other types of specialists. And this to me was really illustrated by some things that one of my very earliest patients said, which is like, I feel like I'm spending my life at the doctor as opposed to getting to do all of the things that they wanted to do. And I think just relevant for this is that even with Medicare Part D, this type of drug regimen is often very expensive for patients in terms of the out-of-pocket costs for people. So this is another way of thinking about that complexity. This was actually created by a woman named Kristen Lind, who had a son that has a rare genetic illness. And she created this map to show that everything that she was trying to manage in supporting him. And as you can see, it's pretty complicated. And while for older adults, we probably don't have school there, but we might. Yeah, there are still an awful lot of things that we might be managing. But the thing that I took away when I heard her talk about it is she talked about how when she showed this map to her son's neurologist, that he said, oh, maybe I could see you every 4 months instead of every 2 months. But I think that many of us don't have any idea how much everyone else is asking patients to do things. And I don't think we do a great job of prioritizing, like, what are the most important things. We also don't do a great job of like trying to really make it easy and efficient, right? Like, it would be nice to be able to see your physicians on the same day, for example, but that can be complicated. This is another just sort of illustration of this concept that I think is an important one for patients and their families to recognize, because I actually think there's things we can do about it if our attention is drawn to it. And then this is just another illustration, which I think shows that point, right? That this is from another patient who created it. She has Parkinson's disease, and she talks about how much she spends on self-care versus how much time she's actually with the doctor, like really showing like just how much what we see is a tiny snapshot of what patients are experiencing. So this concept is sometimes referred to as treatment burden, which I don't know if it's the greatest term, but it's really this idea of how much we're asking people to do. And as people have more conditions, and in this paper, it's used, the term multimorbidity is used. This is from a paper from authors in Europe, and that tends to be the term that's used there. But as conditions get more severe, more complex, there's more likely to be interactions, not only between the way we treat conditions, but between the conditions themselves. And so, as both the number of physicians, the number of appointments and admissions, the amount of medications, as those go up, as well as the conditions go up, it becomes even more and more important that we figure out how to get the patient back at the center. So this is a concept called age-friendly care, which I really like. I hope you do as well. Really, one of the central things is to think about how can we help manage when there's that complexity in a way that really keeps the things that matter to patients and their families at the center. So what are the 4 M's that are the anchors? So one of them is really knowing what matters most to the patient. What do they enjoy about their day? What activities do they want to be able to keep doing? Is there an event that they want to get better for that's in the future? A granddaughter's graduation. To make sure that we're being really careful about medicines, which I'll talk a little bit about. To be thinking about mobility, which is basically like understanding, how well people can walk. Can they do the exercise they want? Are they at risk of falling? Really just trying to keep mobility as something that we're keeping front of mind. I don't know how many of your doctors ask you about how well you're walking, how far you're walking, and or whatever activities it is you enjoy, but it's really thinking about that because it's so important for independence. And then finally, mentation, which is both mental health as well as cognitive health. We know from older adults that both of those are really important to people. And so this framework is to think about these as bases, right? And you'll notice none of them are a disease, right? But just trying to think about them in terms of the impact that they have on our patients. So briefly, I'm just going to share that as part of some of our earlier work, one of the things we know is that a lot of times the evidence about safety and how well a drug, for example, works, come from studies that were done on younger people or people who only had that one condition, right? They only had heart failure, or they only had bladder cancer, or they only had, asthma. But we know that many times people have other things, which then makes it important for us to really be thinking and studying, well, how is this going to affect the person in front of me? What can I do to make sure that they do well with whatever treatment that I really think is important? Are there things I could do that would make it better tolerated, right? Like sometimes older patients actually need dose reductions if their kidney function has changed. Oops, sorry about that. So this is just another illustration to show that while most guidelines for your doctors may say, oh, if the person's on this, it may be not a great idea to also put them on that. But in general, a lot of our evidence, and this study was actually repeated about 10 years after our original work, and showed that there'd been a little bit of progress, but we still have ways to go, that unfortunately, the tools at your physician's fingertips may not be ideal for figuring out what to do when people are faced with multiple things. So I like this illustration, which shows polypharmacy. So what's polypharmacy? It's being on multiple medicines. I think this sometimes illustrates what people might feel. And I think it could say that this is the unintended consequence of good healthcare. Sometimes people get on medicines that we really wouldn't have been good for them. But oftentimes people accumulate a lot of medicines because we're trying to do a good job for each of the individual conditions. But the number of medicines one takes matters. So adverse drug reactions, if you're on 2 medicines, you have a 12% chance of having an adverse drug reaction. If you're on 7 or more medicines, there's an 80% chance that there's some sort of an interaction or a reaction that, it may not be super serious. Sometimes they are, but that may give you new side effects, may end you up in the emergency room if your blood sugar goes too low or your blood pressure is too low, just as some examples. Transitions means if you're coming out of the hospital back home, that's a risky time. Like the doctors in the hospital have sort of one idea of how you're doing and what medicines you need. But then you go back home and it could be that something you were on at home hadn't gotten into the record of the hospital, and they've added something new that's then going to interact. And so generally what we like to think is that as we add medicines, we want to rock the boat slowly. And similarly, as we try to take them away, we want to be careful. There was an article in the New York Times called in the new old age column, looking to tackle prescription overload. I'm going to tell you a little bit more about the patient who was featured in it, who's was the patient of one of my colleagues. So these are some of the drugs that definitely sometimes people need them. Like if you're on one of these medicines, you absolutely should keep taking them until you talk to your doctor. I'm in no ways trying to deter people for that. But sometimes, as just one example, oral hypoglycemics, as our bodies change and our kidney function changes, we may need a different dose of those as we grow older, or we may want to switch to another one. And so that's an example of something where like you would want to be having a conversation with your provider, your doctor, about what's best for you, and has your body changed over time. If you leave with one thing today, I think it would be to come to your doctor with an accurate list, or even bring the medicines with you. And if you don't know what they all are for, ask them. And to ask the question of, could we just take a look at these and make sure I still need all of them and at the same dose? So this patient that was featured in the story was 93 and a retired crossing guard. She had the conditions that you see here. And when my colleague first met her, and her story was shared in the New York Times, so we have permission to share it with you. She was unable to answer questions or stand without assistance, and her cognition was a 3 out of 30, which is 30 out of 30 is normal. This picture on the right is after she got significantly improved, but we didn't have a picture of that, but just kind of wanted to illustrate that she's got a really loving family member who's a caregiver, really trying to help her live as fully as she can. So these were her medicines when my colleague met her, and I'm not expecting all of you to know what they all are, but just to note, oh, I thought I had one where it highlighted them. There's a number of medicines here that might actually be contributing to the slowness and the cognition and the difficulty standing up, and I'll show you a little bit more about it. And you can see a pretty typical box here on the right for a patient that's on lots of meds. So when people are on multiple medicines or polypharmacy, we know that it gets harder for people to take them all. That's adherence. People are more likely to fall. They're more likely to have urinary incontinence. They're more likely to feel like that sense of I'm too many medicines, or I'm spending my life at the doctor, and that they're more likely to have functional decline and cognitive impairment. And so one quote is, the cure may have become the disease. And I should just say that sometimes we treat a side effect of a medicine with another medicine inadvertently. That's called a prescribing cascade. And I think it's just again an opportunity where we can, if we're thoughtful, and this slide illustrates it, this concept of medication stewardship, we can try to really keep people on the right things. So this is the concept, right? Is that there's, for each medicine or thing you're doing, there's going to be potential for benefit, and then there's potential for harm. And we have to kind of weigh these things. I think a really important thing though is it's not cookbook. Like, we have to really know what matters to people, and how bothersome the symptoms are. A symptom that's really bothersome to me might not be bothersome to someone else if it's a side effect of a medicine. And so that patient voice is really important for thinking about that balance. So we want to make sure that we're always looking to see, is benefit going to outweigh harm? And that we want to really be thinking about the goals or the outcomes that matter to people. And that's not always going to perfectly match what's in the guideline. We have to think about each one in the context of everything else, and we have to be willing to monitor or reevaluate, right? Like, if I have a patient try a lower dose of something, I always really set a time where we're going to reevaluate how that's going, and that they can let me know. And obviously, I hope it's clear that patients and caregivers should be involved. But sometimes what we need to do is taper or stop things. So oops, I'm sorry. So deprescribing really is the process of with a provider, could be a physician, it could be a physician assistant, could be a pharmacist, but definitely with a healthcare provider, of trying to decrease the dose, or substituting something that's less harmful, with the goal of improving quality of life and outcomes that matter. So what are potentially inappropriate medicines, which are the things that we might think, ooh, do I really want you to still be taking this? Well, it might be something that's risky, but it might be something that's not risky, but that it's just not really helping you. But if it's not helping, and it's adding to the burden, right? Or it's making your loved one, if your loved one has to take 5 pills a day and 4 of them are unnecessary, right? And having to take 5 means that they forget or decide not to take all of them. It would be so much better to be like, no, this is the 1 or 2 that we really think are most important. And then obviously not aligned with goals. So how do we decide which medicines to think about? And I won't go into these medicines in detail, but one of the things we always think of, and especially for this patient, is what's increasing the risk of confusion, falls, or other drug interactions. So we've highlighted some that for this patient, they may be absolutely the right medicines for you. I just, again, want to be clear about that. But in her, we're likely contributing to how she was doing when we met her. Some other things we ask is, what are all each of them for? It will surprise you that sometimes medicines end up on a list and you can ask a couple people and people are not sure. And so the first thing you have to do is do a little digging and figure it out. But sometimes those are medicines where thoughtfully you can with a provider stop taking them. Are there safer alternatives? Is there a medicine that she needs on there, but that there might be something that's safer for her? And ultimately, what matters most to her, and in this case, her family, because she was, really struggling when we met her. So some of the ways we do this is we ask people, if we focus on one problem when there's several, we may make that problem better, but we may make other problems worse. And so what do you want to focus on? Like, and what symptoms or challenges? Who or what makes you happy? Are there milestones or travel plans in the next 6 months? And then as a way of sort of framing it, right, for trying to prioritize, we could say there are several things we could do, but knowing what matters most, we would suggest you do whatever the thing is. When we're trying to stop medicines as part of this process, I think I've said this before, we want to be making sure we're not doing harm with medicines. We want to emphasize that we're going to support patients in the transition and have a plan where in many cases, right, the dose might be slowly reduced over time. So several medicines were deprescribed for this patient. And I just love this quote from the article. Ms. Harrison, now 95, still needs considerable assistance, but at her 94th birthday celebration in a downtown restaurant with 20 family members, including great-grandchildren, she was the life of the party. And her mini mental had really improved remarkably. And I just love this picture of her and her daughter clearly getting to enjoy each other's company again. So now I'm going to shift gears and talk about a few other things that I think are relevant as we think about all of these things and how they affect people. So one of the things is that about 1/4 of adults over the age of 50 report no leisure time physical activity at all. By 75, it's 35%. And when people have these specific chronic conditions like lung disease, diabetes, or heart disease, the numbers creep up a little higher. But we know that being inactive is one of the strongest predictors of inability to live independently in the future. So one of the main things I try to do is to figure out what kind of activity can people do now? What do they like to do? So it should be something fun. And is there something I could do that might help make that easier? And oftentimes that involves physical or occupational therapy. Not many of us could start out doing what this woman on this slide is doing, right? And that may not even be the goal, but that we can definitely help people get more active and mobile over time with thinking about medicines, figuring out what pain from, so on and so forth. So there's really great evidence that exercise is good for many areas. Weight-bearing exercise is good for bones. Tai Chi reduces the risk of falls. Aerobic exercises reduces the decline in lung and heart function. Many exercises actually end up reducing pain. This is where we really want the physical therapist to be helping us because they can figure out which exercises are going to help you over time have less pain. Resistance exercise can help stave off frailty. And actually we can reduce the risk of dementia with exercise, especially running, and it looks like it cut off. It's supposed to say and walking. So how much exercise? So the take home here is even a few minutes benefits you. This is some illustrations of what might be ideal, but just to note, that I often have people start in what feels like feasible increments, right? If they're not getting exercise, but they walk every day to get the mailbox and back, I will say, why don't you try to do that 3 times, right? Like that's not as much as this, but it's more than they've been doing. So hopefully that makes sense. Now I'm going to shift a little bit and just talk about the brain and cognitive health, and then we'll talk a little bit about social connections and mental health. So some things about the brain. So the brain ages just like other parts of the body, but cognitive aging is not a disease. Cognitive aging is different for every individual, and some people get very little of it, while others get changes that may make other things more challenging. Some cognitive functions actually improve with age, though. Wisdom and knowledge increase, and older adults are actually happier and more satisfied than their younger counterparts. And there are things that we can do to protect our cognitive health, excuse me. So this slide here shows that about 40% of dementia in the world are affected by modifiable risk factors. So you may look at some of these things and not think that they're all modifiable, for you as an individual, but really many of them are. We can do a good job treating hypertension and diabetes. We can treat depression. We should absolutely be helping people stop smoking and getting more active as examples. I'll just make one little note about hearing loss. There's actually a great amount of data to suggest that actually if we treat hearing loss, and this is why it's so great that hearing aids are getting less expensive, that it actually improves cognition, that being able to hear what's in the world, interact and respond to it actually seems to have a protective effect over the long term on cognitive function. So the 3 steps from the National Academy of Medicine are be physical active, reduce cardiovascular risk factors, and manage medications and health conditions that could affect cognition. But some other things that there's increasing data to suggest is that being socially and intellectually active and continually seeking opportunities to learn actually is beneficial for your brain. So all of you are here today, and so you're already doing this. Get adequate sleep and seek professional treatment for sleep disorders. I'll just make the little caveat that many sleep medicines actually can affect falls and cognition. And so I'm not advocating they call it pharmacologic sleep. For some people it's what's needed, but it's one of those things where we really have to think about the pros and cons, and that we want to avoid acute times where people get confused. So I wanted to briefly also talk about social isolation and loneliness. So social isolation is the objective lack of or limited social contact with others. Loneliness is the perception of social isolation or the subjective feeling of being lonely. I was very honored to get to participate on this panel from the National Academies, and my colleague, Dr. Thomas Cujo, has actually done a lot of research, both that ended up being used in this report and has continued to advance this field. But really the take homes is that we want to figure out ways to get people connected. So not just being physically active, but figuring out how to be socially active actually has been shown in multiple ways to be good for our health. So that could be calling a friend on the phone, really trying to have a good conversation. It could be continuing to participate in activities that matter to you at a senior center, a book club. But that really trying to figure out the ways that we stay connected with each other actually is good, not only for our brains, but it's actually been shown to be good for cardiovascular health as well as function. And one of the ways that people have talked about doing this as people are getting older is that thinking about the reason to get up in the morning, it is, and making sure that we're finding and supporting our loved ones in finding those activities is really important. This was an example showing that when older adults volunteered in Baltimore City schools through this program called Experience Corps, not only did the students' outcomes get better, but the outcomes of the older adults were better. So I think this is my last slide or two, so hopefully we'll have time for some questions. I wanted to just talk a little bit about ageism and aging self-stereotypes. So, I mean, many of us have seen birthday cards that maybe take a dig at growing older, and you know they may well make us all chuckle, but there's actually really good data. But I mean, certainly some people that they don't have that reaction to them. But I think the key take home is seeing those kinds of things and then believing them yourself actually has worse outcomes. So people who have positive beliefs about aging actually engage in more preventive care and are more likely to be alive 7.5 years later than people measured at the first point in time who are more negative about aging. And this is adjusting for people's difference in health status to begin with. So it's pretty amazing just to realize that like what our beliefs are and the messages society is giving us actually have health effects, and we should all be trying to counteract that. Oops, I'm sorry. So this is something which is that age beliefs actually can be changed and the impact is dramatic and lasts. So this study took over 100 people over the age of 60. On average, they were about 80. And they showed basically positive messages and activation and subliminal words to one group and nothing to the other. And then measured both their beliefs about aging and how well they could do physical function or mobility. And basically this very brief intervention actually improved not only their beliefs, but how well they were functioning, which I just think is really so striking. So here's one of my pictures to show that there's still many things that we can learn to do, contribute, we can get stronger. I really do think there's, and having that mindset and really trying to build that mindset is actually good for you. So you all probably all could think of a few others, but here are some of the gifts that have been written about getting older. So wisdom, judgment, experience, perspective, being better at emotional regulation, being able to see the big picture and really synthesize things, being creativity. There was an article in the, I think it was in the Baltimore Banner, about a person who's built all this amazing artwork. I think he was in his 80s or 90s. That's now going to be at the Visionary Art Museum here in Baltimore. That had not been an artist his whole life. So just some examples that I hope will inspire you. So the bottom lines are don't take too many pills, but change them in conjunction with your doctor. Exercise, take sleep seriously. We want to grow our brain in healthy ways, that staying connected with each other matters, and working to improve our own beliefs about aging actually has health benefits. So I will stop there.
Thank you so much.
Hi, Dr. Boyd, it's Stephanie. That was so fantastic. I have a lot of questions for you. And
Great.
You make it seem, if every human who experiences, over age 70 could have a physician like you, I think we'd be a better planet. So you've been so thoughtful and so deliberate about thinking through the patient experience. We're not even really talking about a patient with bladder cancer. We're just talking about yes, aging and other things that come along with aging. You know, you mentioned cardiac, heart, sleep. You mentioned other issues, diabetes, other asthma, you know, other things that come along in our long lives. How can a patient who has several things going on, and maybe on top of it all, a diagnosis of bladder cancer, who is not seen by you, what tips do you give them or their caregiver to ask the right questions and to sort of, maybe demand is too strong, but demand sort of a comprehensive look at the whole person? Um, in the context of bladder cancer, it's so intense, and it's a very it's very treated. So you're in for periods of time. You're very in touch with your urologist. The checkups are frequent. The treatments are difficult, depending on what stage you are. And oftentimes, I can say this from my own husband's experience. You know, all you thought about at that appointment was bladder cancer, and then all of a sudden there was like all these other things going on too, that you never sort of got to, like, how does this work with the other stuff that I'm dealing with as an older person? What advice would you give patients who don't have the benefit of you? They do have the benefit of your talk, now memorialized forever on our website, and it was fantastic, to ask or compel their care team, which means it's a big team, maybe not so coordinated, to sort of make sure that at minimum the medications aren't working against each other or causing falls, or, you know, lack of sleep. Bladder cancer patients, on the by the way, suffer from a lot of sleep deficits, because their bladders tend to be, I can say this, you know, very active, and so sleep is hard unless, you know, as you go along. What advice would you give to sort of compel your medical team to look at the whole you?
Yeah, I think that's a great question. And I definitely think one of the number one things would be to figure out a system where you're keeping an accurate list, or you're doing it for your family member, of what the medicines are. And that when someone's starting something new, right? That you're saying, could you just take a look and make sure that this isn't going to affect anything on here? Many times you can do that when you check in for an appointment. Sometimes you can do it on my chart in advance. My chart is not always easy for people, and I would definitely say, if it's not, just, bring the list kind of with you, but really being sort of prepared to ask that question. Just for an example, right? Some treatments for cancer may make people really not want to eat, like they feel nauseous, just for an example, right? Which is a time that if people are losing weight or getting a little dehydrated, that they may actually need less of their blood pressure medicines or less of their diabetes
Oh,
medicines.
wow.
So it's just important to be thinking about that, so that you're asking the question, like, okay, if my loved one doesn't eat for 24 hours, should I still give her these 3 meds? Do you know what I mean? Should I still give her these 3 medicines, or how would I make a judgment about that? So I think that sort of accurate medicine list and being willing to ask the question is, I would say that is number one. I mean, I think a second thing is really important, and is just really understanding, um, when we all get those informed consent things, right? Like there are a lot of words, there's a lot of things there, right?
And they give them to you at very awful times before something very stressful is coming along, and we never read them, honestly.
Right.
It's
Yeah. So,
terrible.
yeah. So I think we all do need to know what are those rare reactions that you might get. But like, I would also ask, like, what do you typically see? Like, what typically happens? Like if and what typically happens in terms of a side effect I've got to get through, and what typically happens in terms of the outcome improvement, right? Of the improvement in the bladder cancer or whatever it is, um, with the treatment, right? So that you have that sort of front of mind as you're weighing decisions. And I think sort of being upfront about what you like to do and what matters to you to either be able to keep doing, or that your goal is to be able to get back to doing that again. So when I was in medical school, there was actually a vascular surgeon who the first thing he used to ask his patients was, how do you spend your days? And then like, and how do you want to be spending your days? And so and he was brilliant, and he was so smart. He was definitely like ahead of his time. But I think being willing to just say that, like be willing to say what's important to you. Like, I want to be able to get back to doing this, or I need to be able to keep taking my dog to the backyard, like, whatever it is. But just because I think sometimes our system does not design us to be keeping those things front and center, but they really should be kind of the anchor that everyone is guided by.
Sometimes I think patients in general are afraid to ask questions or afraid to offer information that gives more of a sense of the whole person. My goals are. So I guess I'm asking kind of a softball question here. Patients have every right to say what matters to them, even though they perhaps may not be asked that question, if ever. And again, we have, for bladder cancer patients who are all over the country, and the numbers are sadly rising. I just saw that, and go through a lot. They also don't often have the benefit of what I would call it a benefit of an academic medical center that sort of tends to take a more comprehensive view of things. Maybe when they see you, you also are very keen about, diabetes and heart. And when you're in a different part of the country, you see your oncologist, and then you see next week you go to so many appointments. That's what we hear all the time. So it's not coordinated care. So having a list of medications that you just sort of, yes, they ask, but do they read it? I don't know. Have it and say, does anything conflicting with something else, is a really good idea to get started, I imagine. What about the role of pharmacists, your local pharmacist, who you probably see more than your physician? They're a great resource, isn't that true?
Absolutely. Yes. No, I would say that anyone who has built a relationship with a local pharmacist, I would definitely say that's a tremendous resource. I think sometimes when people get things from mail order, it doesn't always end up feeling like that personal. Do you know what I mean? That you could just know, oh, let me ask when I go to pick up. Like, but many of the uh increasing number of clinics actually will have an affiliated pharmacist that may not see every patient, but that is actually something that you could ask, right? Like, hey, like, I feel like I'm taking a lot of medicines. I'm worried about side effects. Like, do you have a pharmacist that works in your practice? Or is there one that's affiliated with the, in any way, the clinic? Or if you have a pharmacist from your community that you have a relationship with. I think it's actually really a tremendous research, and a lot of the good research around polypharmacy and medication stewardship and deprescribing actually has been built on having a pharmacist as part of that team.
Mm-hmm. Now about the role of the caregiver. They
Yeah.
play an exceptionally important role, and it's a hard role at times. At what point, difficult question, no, let's go back to bladder cancer. It's very intense. First of all,
Mhm.
most people have never heard of it, and all of a sudden they have this awful thing, and it's a mystery. There's also quite stigmatized for some reason, which we are trying to change, because it's the bladder and it's urine. I don't know. We talk about prostate cancer all the time, and we talk about breast cancer all the time, not to malign those, but like, oh, bladder cancer, we can't talk about that. So the treatments are fairly rigorous. The follow-up is very rigorous. You'll see your urologist and perhaps oncologist for a concentrated period of time. You'll be given standard practice for non-muscle invasive is BCG. It's can be quite nasty. It's exhausting. It's irritating. For older, this is hard to quantify this question, but you go through cancer treatments, whether it's bladder or breast, or you have chemotherapy, you have a surgery. Do you see your patients recovering to where they were, or is there typically statistically more of a decline in their abilities after they've gone through a sort of major significant cancer experience? When there's a time when there's treatments, and there are times when you sort of get a break or they stop. What is the crystal ball in terms of longevity after a cancer diagnosis? In particular, bladder is a tough one. It's very, very tough.
I mean, I'm definitely not a bladder cancer expert, but the thing that I would say is that I do think that there's variability, right? That I think it's very hard to make a broad generalization about it. I think, you know, some of the things that I tell my patients, right, is so let just go back to the mailbox example, right? When it's exhausting and you're in the thick of it and you really feel awful, but then there's a period when you're like doing a little bit better. One of the things that I tell my patient is like, look, I know you used to walk 3 miles a day, but let's get you doing 2,000 steps or to the mailbox and back, because doing that when you feel good actually helps build the resilience for the next. Do you know what I mean? The next time, you know, so that message of really like, you know, any activity that people can do and not feel awful while they're doing it, like it is actually good at making you sort of stronger for the future. You know, I do think that people, there's definitely patients who do well, right? And the body really is quite resilient. I think a key thing is that you go slow, but like we have to be sort of taking the steps to kind of get there. Like it doesn't just come back by itself. You've got to be you know, trying to do it kind of step by step to really recover. Now I'm talking about like when, you know, the treatment is kind of over. I definitely would say that you know, I think when we're thinking about having a world that's more inclusive, more accepting, right? Like that would mean like we all have to go to the bathroom. Like we all should just feel like, you know what, like if I need something, then I'm going to ask for it, and like not let things keep us from going out and participating in the world. They talk about like not only age-friendly hospitals, but we should be like a age-friendly community, right? Like so people who've gone through any kind of difficult treatment, right? That our default is try to figure out how do we make it easy and accommodating and accepting. But really just trying to get back out there in the world in whatever ways that matter, right? And so for some people, that's going to look very different than others. And sometimes we have to find an activity that sort of temporarily substitutes. But right, those things like maintaining social connection, you know, figuring out how to do that while you're going through treatment, you know, is important, because when people just sort of lose all connection with like because they're going through something so difficult, like when able, we want to figure out what to substitute. You know, is it phone calls? Is it a Zoom call? Is it letting somebody stop by? You know, don't say no when people offer to do something. Like it might actually be good for you to say yes and to have a friendly face at your door. But so I think that would be the other piece of the advice for me. And I think that that's good, not only for the patient, just to bring it back a little bit to what you started with, but it's also good for the caregiver. So,
Right.
you know, right, I would think about these things a little bit going hand in hand, that we want the health of both people to be able to come out on the other side of things.
What is the role that you recommend of nutrition? So bladder cancer patients, you know, oftentimes end up with urinary diversions, which
Mhm.
it's my understanding sometimes there's not as much absorption of
Mhm.
critical vitamins and minerals. Anemia is um, present, or calcium. We're actually going to have a presentation on bone health in the fall,
Oh,
um,
good.
because you know the longitudinal studies, there aren't many on people who've had diversion, say 20 years ago, which is amazing. You know, they're doing great. 20 years
Yeah,
ago
that's,
they had
yeah.
bladder cancer, like yay. But it's sort of unknown what, you know, as it goes on. Anecdotally, we chose a topic because we have a dear friend who all of a sudden had like terrible anemia out of nowhere. She had no idea why. She was short of breath, and she's just this incredible human being, active, amazingly young at heart and young in spirit. And it turns out she was anemic because there's a suspicion that, you know, she's not absorbing as many minerals and vitamins, like because of this urinary diversion, which affects the digestive system. What um, role does nutrition play in when you counsel patients to sort of lead healthy, deprescribed, active lives? What I, I know you're going to say fruits and vegetables, but go ahead and say it.
I I
And
am
also
gonna,
appetite. Appetite
yeah.
is a huge problem with bladder patients after surgeries and after treatments, because they're just not hungry. What do you do to sort of encourage someone that food can be medicine?
Yeah. So you're right about fruits and vegetables. I would say one of the key things is small, when people really don't have a great appetite. So small meals 5 times a day, you may actually get more calories into people than, like, do you know what I mean? Like having 4 bites of a big dinner, right? Like it could be that you just want to try to have it multiple, you know, like the thought of like spoiling appetite, right? Like if all you can get down is 4 or 5 bites, you probably could do that 3 hours earlier and do it now. Like the 3 hour mid-afternoon snack, like you can tell like I'm still in that I still have a kid, right? Like the idea that's going to ruin dinner, like if people's appetite is really bad, like it's actually the opposite. We end up getting more calories into people if they have small um uh uh healthy food, you know, more times a day. And so like
Yeah.
you know, and so sometimes when you're really going through things, right, like what we might tell people to eat might look a little different than, you know, when they're out, you know, back walking, you know, 2 miles a day,
Mhm.
right? Like what we'll tell people to eat. If the only thing that looks good to your loved one is a milkshake, like get a milkshake, but I might try to figure out, like, could we get some protein in there? You know, could we add a banana to it? You know, but like,
Mhm.
you know, so a little bit, it depends where people are. But I think when there's really that loss of appetite, small meals that are something that people like, that have a you know, a decent amount of calories to them, is important. You know, I definitely would say that the other pieces, right, that I tell my patients is balance. Um, and you know, fruits and vegetables, one of the reason that that's great is it can really help with constipation.
Oh
You know, a
yeah.
lot of medicines cause constipation. You know, when people are going through surgery, like they can end up with constipation. It sounds like, you know, with the diversion, sometimes that's not what happens, but what you actually eat can really actually affect how much medicines you need. I think that the other thing, I mean, that I would say is, you know, just like, it- you know, like I wouldn't want someone to have McDonald's like every day, right? Like, but like if it's your birthday, like have a piece of birthday cake. Do you know what I
Right.
mean?
Eat ice cream. Yeah.
Yeah. You know, but, and I would definitely say that the like the balance, like the lean meats. One other thing I'll just say about bone health, not to preempt whoever is coming, but we actually know that the body better absorbs calcium when it's in food than when it's with pills. So, you know, trying to make sure that the diet has a reasonable amount of calcium in it actually is good for bones. And the pill is not better than food. I mean, sometimes we need to use the pill, but the body actually absorbs more of some of these nutrients if we're getting it through you know, food that we're eating.
Right. So this has been fantastic. We wish you were all our doctors because you really have thought just an incredibly nuanced, careful, sort of comprehensive look at all aspects of our lives. This is a hard one. I think I'd like you to comment. You mentioned so many of the gifts of getting older that often are neglected. And I took a picture, you know, perspective, wisdom, judgment, experience, social values, etc., creativity. How do you counsel a patient? And this is hard for our bladder cancer patients, and I'm asking for a reason to give some hope. How do you counsel when a patient really has just despair? They're just exhausted and tired of being poked and prodded and having so many medications and so many doctor visits. I don't think the doctor visits would be to you, but they would be out there in general. It's common to say all I do is go to doctors. What do you say to your patients who are feeling a little low about getting older and, you know, having so much of a medical onslaught? How do you help um, counsel them?
Yeah. Some people that I think would really benefit, right, from mental health care, right? Like getting to talk to a counselor, getting to sort of work through all that you're sort of going through. And that could be one-on-one, it could be in a group, right? But, you know, like just sharing with others, actually there is benefit. And so, you know, for the people who are you know, really feeling that way, if I was their physician, I'd want to be exploring with them, with their family member, like, you know, is there something we could find that would give them support through those difficult times. I think that, you know, because obviously it's a spectrum, right? But I think also figuring out how to notice things. I probably could give you a suggestion or two for future speakers, but some of my colleagues have really like done a lot of reading about kind of how do we find joy in smaller moments, you know, and like how do we really sort of recognize them and appreciate them, and how does figuring out how to do that actually help? I mean, I think remembering that, right? Like you know, the treatment does not go on for, at least as I understand it, it's a period of time, and then
Correct.
it's gonna evolve or change or stop. And so trying to hold on to that's coming, and sort of really figuring out how to, you know, find things in the moment that are helpful. This is, my mom did not have bladder cancer, but just as an example, you know, my mom, who has since now passed away, she got really tremendous joy by getting to see videos I had taken of my kids. You know, as she could get out more, right? Like she would much rather watch a video of her grandchildren than like watch the television. Do you know what I mean? Like, and so
Yeah.
like we set up like so that it was like just like a simple push button. They have all sorts of new gadgets, and I'm not a very tech person, right? Where like you can even remotely be changing like what's on a screen, like just sort of
Mhm.
an example of that, like, you know, when she was not, when she was, there was a period of time where she was going through a lot and she couldn't get out and do all the things she wanted to do, but like really just finding those ways of trying to figure out that connection. You know, is it phone calls, is it visits? And so You know, my hope would be that people who are feeling that way will also feel, you know, empowered to seek out help, ask for a visit or a phone call, or, you know, and just be willing to sort of say, like, what makes a difference versus what makes you feel worse. I think most people who want to help really want to know what actually would help, and it may feel like sometimes there's really not anything, but you know, if what someone wants is not food but just company, like being willing to say that, you know, like, you
Yeah.
don't have to bring me food, but I'd love you to just sit outside with me, you know, for a half hour. And especially now it's spring. Hopefully it's spring where most people are.
Well, these are wise words, because you anecdotally experience this with your patients. They've had moments of despair. Certainly our bladder cancer patients, every single one goes through it. It's super tough, but I guess the message is you can get through it and find you are wise, and you have gifts as a person who's maybe over the age of 20 and
Oh, goodness.
certainly like, and that those skills come in handy, and that there's a lot to live for. Thank you, Dr. Boyd, for this really wonderful conversation. We learned a lot of tips from you today, and we just hope that everyone out there could have a physician like you, or are empowered to be a great one of your patients, to sort of ask the right questions and make sure that all the things going on are coordinated and working to treat the whole person. Thank you again for this wonderful talk. Our next talk for the women's program, by the way, is on June 18th. And it's for our women's bladder cancer program. And it's on June 18th about coping skills, but we have some psychologists and psychotherapists joining us for that. So we're always all about helping our patients feel their best selves. Thank you again for today. It was really wonderful. And David, sorry I didn't let you say one word.
No worries.
Thank
I've
you.
learned a lot today, and I look forward to putting some of these things into practice. I think you've given us some great ideas.
Thank
Take
you
care.
again.
Love you.
Thanks
See you
everyone
soon.
for tuning in. Bye-bye.